Dr. Sanjeev, the chief of the now world-famous Amrita Institute, which was inaugurated by the Prime Minister recently. But Sanjeev is famous on his own. Let me tell you, ladies and gentlemen, no conference can be complete without his charismatic presence. So he is going to lead this panel discussion today. We have absolutely illustrious panel in this particular discussion today, which is the challenges and opportunities for the healthcare institution. So Dr. Sujit Chatterjee, who is the Chief Operating Officer of the LH Hiranandani Hospital in Mumbai, needs no introduction. He again has been a very important part of the various CAHO programs and deliberations. Dr. Chatterjee, more and more hospitals are moving towards adoption of EMR. Has patient safety quotient improved after implementation of EMR, or is that a mirage?
Well, thank you all, and thank you, Dr. Vijay Agarwal, for having me on this panel, and I thank my co-panelists for being there. And I can assure you that it is not a mirage. We have been all working towards electronic medical records, and electronic medical records are even finding space now in the legal forum. Just a couple of years ago, I would just say just 2 years ago, the courts demanded that you have to have original handwritten documents. But today, when you publish or print electronic medical records, they are more than accepted. Of course, it has to be in the patient's case file, but it is more than accepted as original documents. And the only thing that they insist upon is that wherever the doctor has put a signature, that is, a scanned signature, the stamp should come there. That being said, we as doctors don't really have the bestest of handwritings, And if you're talking in terms of patient safety, I would like to tell you that there are so many occasions where a doctor fails to start off with the most basic, which is the date and time of examination. And with an electronic medical record, it is there. It is not only now safety for the patient, but it is also safety for the doctor, and it's safety for the institution. At the same time, there are notes which are completely legible until and unless you're uneducated and do not know how to read and write. I'm sure you will be able to read typewritten documents. The errors which occur in prescription and transcription are to a very large extent. And if you ask me to quantify what is large extent, I would say 99% of the time, the documentation, the transcription and prescription error is avoided. And at the same time, the instructions to the nurse or even the recommendations of dosage are so clearly manifest until, of course, there's a typographical error. Yes, of course, that is per chance. But until and unless that is so, the instructions are so lucid and so clear that the mistakes in giving the wrong medicine to the wrong person at the wrong time, or even the wrong dose, or even by the wrong route, are completely avoided. So I think that this sort of system of keeping records, and which can be stored, like you have voluminous, when we design hospitals, one of the things that everybody says is that you should have a very extensive, large medical records because you have to store so much of data. Sure, you have to store so much of data, but doesn't require enormous amount of space, or it doesn't require compactor cupboards to ensure that the data is kept. This is at the click of a button, the data can be received, records can be maintained, records can be sent across to people, including within the organization. The primary consultant and the consultants the primary doctor refers to can see the records online. So therefore, I think electronic medical records is nothing of a mirage. It is a boon, and it has to be modified. And there are newer things which have to be introduced into the system. For example, small things like drop-down menus with the ease with which the doctor can prescribe or put the data down so that the speed increases. Not every senior doctor is tech savvy. But the fact of the matter is that the generations which are coming up are all going to be using computers and electronic medical records. Should you not provide that, then I think you'll be a laggard. This is what I need to say in my opening remarks, Dr. Agarwal.
Thank you, Dr. Chatterjee.
So, Dr. Sujit, is there any quick examples of CDSS implementation and its patient-related outcome?
Well, as far as clinical decision making is concerned, the clinical pathways which we follow extremely strictly the clinical pathways, and we have people who are given the task of ensuring that the clinical pathways work right across from admission to discharge. So therefore, we've been able to maintain our average length of stay to about 3.5 for the last 4 years. And at the same time, I would just like to tell you that the clinical pathway helps to such an extent that you find that the patient stay in the hospital is dramatically reduced. For example, single knee replacement, the patient goes home on the 3rd day, including the day of admission, and bilateral knees go back on the 5th day, including the day of admission. Now, this could have only been possible if we had these, or if we didn't, with the use of these clinical pathways that are there. So therefore, at every stage, if you analyze what was an outlier, then you can cone it down, and you have an enormous benefit as far as patient is concerned and the standardization of care. So therefore, you will be actually reputed to have a particular standard which is a very high order. And this is all thanks to clinical, based algorithms which come in. So if you call it an algorithm, you call it a pathway, it's arose by another name. But the fact of the matter is, these are such useful tools. And I can go on and on because I have a large number of pathways which we've put down and we've adopted. So therefore, I quite agree with Dr. Panigrahi, who said, Vishnu Prasad Panigrahi, who said that these sort of things are the way forward. And if you do not have this, I think we will never be able to have standardized care and have variable outcomes as to opposed to standardized outcomes.
Thanks, Dr. Sujit. Very rightly mentioned about standardization and clinical pathways and the treatment guidelines adoption. So we now come to the end of this discussion, and a very quick word for you. Still think that digital transformation and adoption, is it a challenge or is it an opportunity? Dr. Sujit.
Well, of course, it is an opportunity. I mean, there's no denying. You've heard the co-panelists speak so extensively on all of this. I just would like to not say one thing, that there is no opportunity. It's a huge opportunity, and we must grab it, we must embrace it, and we must try and ensure that people also are like clinical colleagues find it very acceptable. However, at the end of the day, no matter how much of automation you want and how many systems that you put in, the human element should never be lost. Because if that is lost, then we are just as good as robots who are programmed to do something. So we shouldn't get carried overboard, and the doctor's touch, the nurse's touch, the empathy and compassion has to be in the forefront, no matter what you think in terms of medical records and digitization and embracing digitization. Thank you.
I have always loved your honest and realistic opinion. And on that sweet note, where it is a huge opportunity, but we should not lose the human and empathetic touch, I think we will close this session. It has been a great learning from listening to all of you. And I know there are challenges, but there are huge opportunity, and let's encash on this to improve effectiveness, to improve efficiency, to reduce cost, and ultimately patient outcomes. So thank you so much.